symptoms. We're going to start with congenital infection. Uh, Congenital infection are uncommon nowadays, but frequently you get the question in the MRCP Part 1 exam. They are remembered by a mnemonic called TORCH infection, TORCH, which stands for toxoplasmosis rubella, cytomegalovirus, and herpes group of virus. Among them, CMV is the most common cause of congenital infection in the UK, but remember, most of the cases, both the mother and the child may be asymptomatic. This table highlights the different characteristics of the three common diseases. So we're going to begin with CMV because this is the most common congenital infection. So the common, about 90% of them are asymptomatic. You can have some growth retardation or purpura in the newborn baby. Apart from that, you can have some hearing loss, encephalitis, pneumonia, hepatosplenomegaly, anemia, jaundice, and they can have cerebral palsy. Okay, these are the manifestation in the baby after the birth. But remember, cytomegalovirus is a small virus. It can infect any part of the body. Next is the rubella. So rubella characteristic feature is hearing loss and cataract. They usually have congenital heart disease, especially patent ductus arteriosus. They can have congenital glaucoma. The risk of infection is highest in the first trimester. Okay, 8 to 10 weeks of gestation, that is in the first trimester, where the fetus does not have much immunity, and so rubella virus can invade quite easily into the fetus. So the highest risk is in the first gestation, first trimester. In addition, the child, the baby can have growth retardation, hepatosplenomegaly, microophthalmia, and cerebral palsy as well. Toxoplasmosis, you are going to manifest with the cerebral calcification, chorioretinitis, which is inflammation of the retinal layer along with the choroid. You can have hydrocephalus. Remember the key terms here. If you are going to have rubella, so you're going to look for hearing loss and cataract and heart disease, and even the microophthalmia, which is a small eyeball. In case of toxoplasma, basically you're looking at this term, cerebral calcification or chorioretinitis. In CMV, most of the time it is asymptomatic. Uh, could be one of the symptoms could be purpura or growth retardation. Okay, these are the common symptoms and how to identify a particular clinical condition or how we can differentiate each of these conditions based on the common features. So one of the other congenital syndrome is called fetal varicella syndrome. That is, if the mother get exposed to varicella and the mother has varicella or chickenpox, then the baby is at risk for developing what's called fetal varicella syndrome. The risk of infection is only 1% before the 20th week of gestation. And there are some small number of cases between 20 to 28 and nothing beyond 28 weeks. So it is basically in the first trimester where the risk is highest. The clinical feature, what you can get in the baby is the scarring of the skin, eye defect, which is microophthalmia, limb hypoplasia, microcephaly, and some learning disabilities. The clue could be history of some rash during first trimester of pregnancy. That indicates that the baby might be having fetal varicella syndrome. Other disease which has become very quite uncommon congenital disease is called congenital syphilis, where the baby can have rhinitis. So this is the rhinitis, continuous nasal discharge. There are some bullae in the skin, abnormal dentition. The child may have abnormal dentition, interstitial keratitis, and sensory neural hearing loss. Toxoplasma infection. Remember, toxoplasma is a protozoa which infects the body via the GI tract or by the food or by the broken skin. The common risk factor, consumption of contaminated water, food, or meat from infected animal. Okay, I'm going to discuss the life cycle in the next slide. But remember, it's basically the sheep and the goat are the part of the life cycle of the toxoplasma, which maintains the pool of toxoplasma. Usually, the infective forms are the trophozoites, which once enter the body, they go to the different part of the body, such as eye, brain, and muscle. They have predilection for brain, okay, and for the eye. That's why you see the cerebral calcification or space-occupying lesion or chorioretinitis as one of the manifestation of toxoplasmosis. Okay, the usual animal reservoir is the cat. Okay. The vertical transmission is common, like human to human transmission. So they may ask a question, in which disease you get human to human transmission. Okay, and they give a lot of many of the option. One of the option is toxoplasma. Remember, toxoplasma. When they say human to human transmission, we may not remember the vertical transmission. Okay, so remember, human to human transmission does not mean passing from one adult to another adult. It could be from passing from a mother to a baby. Is also human to human transmission. Okay, so do keep this point in mind. This is the life cycle of toxoplasma. So usually it is shed in the feces of the cat is a main reservoir. It is shed in the feces of the cat, which is can be consumed by multiple other small mammals, and it can develop toxoplasma in them. Okay, but unfortunately, sometimes it can be consumed by larger mammal, and which through the food chain can enter the human body. Okay, remember human body. So once it enters the human body, the trophozoites, which are the infective forms, enter and they form the what's called tissue cyst. So the predilection is for the brain and the eye. Okay, remember there's no direct transmission from one to other. It's a dead end infection in one particular human being, except if she's a mother, and then only she can transmit it to the her fetus. So most of the human infections are asymptomatic. Symptomatic symptoms, initial symptom could be like typical of infectious mononuclear-like symptoms. So they can have fever, they can have malaise, and they can have some lymphadenopathy. Rarely, it can manifest as meningoencephalitis and myocarditis. So if you do investigate, you might find positive serology, including IgG. So IgM indicates acute infection, IgG indicates previous exposure. So serology indicates past infection can be positive in asymptomatic individuals, because most of the adults with toxoplasma are asymptomatic unless they are immunocompromised. And treatment you are going to do give pyrimethamine sulfadiazine for at least 6 weeks. A congenital toxoplasma is usually present with microcephaly, hydrocephalus, but the key term is cerebral calcification or chorioretinitis. So the key term here for the exam is they're going to ask, they're going to be a typical case of toxoplasmosis, especially cerebral toxoplasmosis, where you're going to have calcification or intracranial space occupying lesion, especially in a patient with HIV. Okay, and they're going to ask what could be the treatment. Okay, the treatment is usually sulfa group of drugs, pyrimethamine sulfadiazine for about 6 weeks. These are the tissue trophozoites, which can be seen in the tissue. This is a chorioretinitis where you can see the pigmented lesion in the retina. Moving on from congenital infection to osteomyelitis. Osteomyelitis means infection of the bone. Usually it's hematogenous, and most common organism is staphylococci, unless it's a trauma. If it's a trauma, usually it's polymicrobial. The common symptom could be pain, fever, some redness or tenderness, or discharging sinus. So usually in a long bone, we have three parts. The middle part is called diaphysis. The tip is called epiphysis, and in between the epiphysis and diaphysis, we call metaphysis. Okay. The remote metaphysis of a bone is the one where there is a rich blood supply. Okay, so whenever there is an infection, usually it infects infection starts from the metaphysis, as you can see in this picture. Okay, so what happens on this infection? There is an inflammation there. Inflammation lead to local hypercoagulability. The blood supply gets blocked, and you have localized necrotic tissue. Okay, so the surrounding bone gets necrotic, and that dead bone is called sequestrum. Sequestrum is basically a dead bone around the site of infection. Now, whenever this a dying bone will release some cytokines which will stimulate the proliferation of new bone. The new bone is called involucrum. Okay, involucrum is a new bone formation which is surrounding the dead bone. Okay, now when there is a formation of new bone, what happens? There is a periosteal reaction. The periosteum gets elevated. Okay, so these are the changes what you can get in the X-ray of a patient with suspected osteomyelitis. This vertebral osteomyelitis, patient can have fever, back pain, and MRI may show destruction of the vertebra with some paraspinal abscess. You have to treat with flucloxacillin. Okay, remember it's a staph aureus, so you're going to give gram-positive coverage, and one of the important drugs against gram-positive is the what's called as the aminopenicillin. Okay, aminopenicillin such as flucloxacillin or ampicillin or amoxicillin. They have extended spectrum of activity. Prosthetic infections. What is the prosthetic joint infection? Early, we it can be classified based on duration of infection as early and late. Okay, delayed is early is less than 6 months, delayed is beyond 3 months to 1 year, and late. Okay, so this is usually seen after hip arthroplasty or knee arthroplasty. Okay, remember knee arthroplasty, the commonest prosthetic joint surgery done in the world, including UK. Okay, so the common organisms are usually commensal, which are present in the skin, such as staph epidermidis. It could be hematogenous infection as well from abscess somewhere else in the body. Typical features are a pain and fever, night sweats, restricted movement of a joint, especially knee joint or hip joint, because these are the two joints which are commonly which are involved in arthroplasties. Acute epiglottitis. We know epiglottis is a small cartilage which is covers the larynx. Okay, it's so infection of that is quite common in children. Okay, you may not get this question in part one, but just to be complete, because there have been few questions have been asked in this topic in the previous exams. So acute epiglottitis, what we need to remember is it is caused by the H influenza type B, and it's also called Hib H influenza type B. Common in children. We have Hib vaccine, which has decreased the incidence of acute epiglottitis. A child will usually present with the rapid onset of fever, looking unwell. There could be stridor, because what happens that when the swelling is there at the epiglottis, the inflammation will also spread into the larynx, and then the vocal cord will get narrowed. So the child will have stridor. There'll be drooling of saliva, because what happens to make a swallowing movement, there should be movement of the epiglottis, and epiglottis movement will be quite painful. Okay, because of the inflammation. That's why they will try to avoid swallowing. So that result in pooling of the saliva and drooling of the saliva. So commonly again, a drug what we choose is coamoxiclav, which is one of the good drug for gram positive bacteria as well as gram negative bacteria. Acute otitis externa or malignant otitis externa. So you might have seen just acute at otitis externa, which is quite common in children, where there is inflammation of the external ear. But malignant otitis externa is specifically seen in uncontrolled diabetes, where the commonest organism is Pseudomonas aeruginosa. Usually, if you examine such patient, they are usually elderly patient who are diabetic, who have high blood sugar, and you examine the ear, you'll have some swelling in the ear. It's extremely tender, and you can see some purulent discharge coming out from the external ear. Now, this is a very virulent organism, so it can invade into the deeper, it can enter into the middle ear. So in the middle ear, we have important cranial nerve, which is the facial nerve, which runs through the medial wall and the posterior wall of the middle ear. So that can get involved during the extension of this infection. Patient can have facial palsy. Now, this infection can even extend up to the base of the skull, so they can have osteomyelitis of the skull base as well. Next topic is neutropenic sepsis. What is neutropenic sepsis? Generally, it is seen in oncology patients, okay, who are receiving multiple chemotherapies, okay, and here the patient will come with febrile illness, okay, and when you do a blood test, the patient will have very low neutrophil count, as defined by less than 500, okay, of absolute neutrophil count, okay, and these patients are at a risk for sepsis and septic shock, okay. So these patients require immediate empirical broad spectrum coverage of antibiotics, okay. Antibiotic coverage depends on the patient's clinical characteristic, including presence of penicillin allergy. If they're not having penicillin allergy, we'll choose a broader spectrum antibiotic like piperacillin tazobactam. If they have a mild penicillin allergy, you can go for cephalosporin like ceftriaxone plus gentamicin. If they have penicillin allergy, then you are left with teicoplanin, which is going to cover the gram-positive organism, gentamicin, which will cover the gram-negative organism. Uh, Chemotherapy patients, if they present with fever, chills, and rigors, immediately starting chemo, think about Lyme infection. So you might have seen chemoport. So majority of the patient who require long-term chemotherapy will be having a tunneled catheter, tunneled center lines, which are called chemoport. Okay, and these can get infected. Okay, so if not, if the proper care is not given to these chemoport or tunnel catheter, they can get infected. So if you have a patient who's on a tunnel catheter, comes with a fever, you should think about tunnel infection or catheter infection as the first possibility. Pyrexia of unknown origin, so defined as prolonged fever for more than 3 weeks, which persist despite resist the diagnosis after hospital, after a week in the hospital. That means the patient should have fever for more than 3 weeks, out of which 1 week should be in the hospital where there has been no conclusive diagnosis. Okay. So in such patients, we will be doing extensive study, including CT, MRI, contrast of the chest, abdomen. We'll also sending some repeated blood cultures, urine cultures. We'll be looking into the other possibility of tuberculosis and also non-infectious cause of fever such as drugs or lymphomas, leukemias. Okay, these are the other things what we should consider when we're dealing with the patient with pyrexia of unknown origin. So common causes are neoplasia like lymphoma, hypernephroma, which is the basically renal cell carcinoma, a pre-leukemia, atrial myxoma, infection like abscess and TB, or connective tissue disorder like SLE. So if the one of the common or one of the options when you're evaluating a patient with pyrexia of unknown origin is intra-abdominal abscess. Uh, is suspecting intra-abdominal abscess. So what we do is what's called as indium labeled leukocyte study. Basically, we're going to label a WBC with the indium, which is a radioactive material. So if it gets focused on, this is a normal indium labeled study, if which is showing actually you can see the liver and the spleen because there are a lot of WBC there which are pulled as a part of reticuloendothelial system. Otherwise, you will be able to make, for example, it's an abscess in the left iliac fossa, you'll be able to pick up in this indium labeled leukocyte study. Okay, so remember it's a study done for intra-abdominal abscess in a patient with, where we are evaluating for pyrexia of unknown origin. Next is postpinectomy infection. It is common during after spleen because spleen is very important for phagocytosis. Okay, and the most common organism are the capsulated organism like pneumococci, meningococci, H. influenza type B. So these patients require usually lifelong prophylaxis with penicillin or macrolide group of drugs. If you're doing elective splenectomy, for example, you have a patient with ITP, okay, and you want that is idiopathic thrombocytopenia purpura, where you're planning for splenectomy, okay. In such patients, you have to vaccinate at least 2 weeks prior to the procedure. Why? Because production of antibody takes some time, and if you're going to remove the spleen and then you are going to give vaccination, the appropriate response may not be achieved. Okay, that's why in a patient who is planning for elective splenectomy, vaccinate at least 2 to 4 weeks prior to the surgery. Anyway, in emergency splenectomy, we cannot help patient if develops infection may require lifelong prophylaxis.